The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast. After learning about the diagnosis and management of benign disorders of the esophagus, such as achalasia, as well as hiatal hernias in part 1 of this episode, we now move on to part 2, focused on the diagnosis and treatment of esophageal cancer and managing esophageal emergencies.
Let's move on to our third case. Let's say another patient comes in with similar symptoms, heartburn, some dysphagia. He's been treated conservatively for GERD for several years with decreasing benefit. He gets a EGD, which demonstrates irregularities at the squamocolumnar junction, and biopsy shows metaplasia. So cancer is often discussed when we talk about Barrett's esophagus. Before we get to that, what other complications are related to Barrett's esophagus?
Well, I think that so the fear of cancer is probably the biggest complication of Barrett's esophagus, and that's that fear of esophagus is probably in many cases out of proportion to the actual risk of cancer. But Barrett's ulcers would be a situation where there's ulceration of the esophagus right at the junction between the squamous epithelium and the metaplastic epithelium that represents the Barrett's esophagus. And those things probably were a lot more common prior to the ubiquitous use of proton pump inhibitors and other medications. I think that that expansion of that class of drugs, in my mind, has probably made Barrett's more common and made esophageal strictures more rare. And we sort of pick our battle. The patients have better comfort and less injury to their esophagus by peptic stricture, but it allows both the gastric contents and bile to kind of bathe the lower esophagus longer and more continually in patients who have a hiatal hernia and are prone to that condition. But Barrett's ulcers, in my practice, are pretty rare. I think that to the point where I was a little surprised to see it on our outline. If you look back at some of the original papers when Allison and Barrett and Johnston were writing about this when it was a foreign subject, there was a lot of discussion about, is that really the esophagus, or is that kind of a malformed stomach? Is the ulcer forming in the stomach, or is it forming in the esophagus? But all that right now just seems a little bit like kind of academic bickering and not so much a clinical problem that we're faced with on a regular basis.
And what is the surveillance for Barrett's esophagus?
Well, I think the surveillance for Barrett's esophagus depends a lot on the last biopsy. So if you, let's say you are the most typical Barrett's patient, which is somebody who had some GERD symptoms or not, and you had an endoscopy, and the gastroenterologist took some biopsies and showed metaplasia of your esophagus with goblet cells. Now you're bearing that label of Barrett's esophagus. Now, if that biopsy showed dysplasia, either low-grade dysplasia or high-grade dysplasia, then almost certainly the frequency of your surveillance would be a lot faster than if there was non-dysplastic Barrett's. For non-dysplastic Barrett's, there have been recommendations of 1 to 2 years, leaning more towards the longer for surveillance endoscopy. Whereas dysplastic Barrett's, the risk of developing a cancer is much higher, and therefore it was probably worthwhile for much more frequent surveillance.
And to take a step back, how do the risk factors differ between squamous cell carcinoma of the esophagus versus adenocarcinoma?
Well, generally, there's almost some caricatures of patients that maybe the trainee or the listener could kind of get in their mind that really characterize the difference between squamous and Barrett's. And for me, the poster child of adenocarcinoma is going to be somebody who's in their a man in their 50s or 60s who's got a BMI of 34 and a hiatal hernia and maybe metabolic syndrome and some other manners like hypertension, sleep apnea. Those patients are the ones that most commonly are being found to have adenocarcinoma, whereas the squamous cell patients often are thin. They might be more likely to be smokers than the adenocarcinoma patients. There might be some alcohol consumption in both groups, but in general, at least the stereotype for the squamous cell cancer patients is going to be the heavy smoker, heavy drinker, skinny patient, and to the degree that stereotypes apply, those two characterizations are fairly accurate in this case.
And for you, what are the core tenets of working up suspected esophageal cancer? I know as a trainee, it could be a little daunting to look at how it's staged and every single finding. And I was wondering if you had any tips for how to remember different steps in the staging.
Yeah, I think there are definitely some things that people should keep an eye on. Well, first of all, in the early end of the spectrum. The question is, do we try to spare the esophagus or not? And so now we're really talking about subsets of T1 tumors. A T1 tumor is a mucosal tumor, and with endoscopic ultrasound and endoscopic mucosal resection, certain gastroenterologists are really able to kind of delineate between a early cancer that's limited to the mucosa, a T1M, versus cancer that goes through the mucosa and is into the submucosa, a T1SM. Now, and so the T1Ms can often be treated with sparing the esophagus, endoscopic mucosal resection or radiofrequency ablation. Those things are adequate for the most superficial cancers. So I think that's the first kind of crossroads that the trainee wants to remember. Should I spare the esophagus or not? And then the next crossroads is, does this patient need an esophagectomy right out of the blocks, or is there a need for induction therapy, whether it's induction chemotherapy or induction chemotherapy and radiation therapy? And generally, the patients who are T1N0 are often and appropriately treated with just an operation versus patients who are T2 or higher, N1 or higher. Those patients are today generally getting induction therapy prior to consideration for surgery. You have to keep in mind other dimensions of the patient as well. You're not staging just the cancer, you're staging the patient with regard to their suitability for an operation. And of the operations that we do, an esophagectomy is among the most morbid. And so you really want to be cognizant of the fact that the patients with a lot of comorbidities, a lot of frailty, they're not going to do so well with an esophagectomy, whereas a young, fit, vigorous person, they can really take a hit, from a major operation and still snap back and benefit from it. So I think you think about these multiple dimensions. You're staging the cancer, but you're also staging the patient. And for the majority of patients, they present in that middle stage where you consider it locally advanced, and that they're going to get induction therapy first. And so in many instances, you're not forced to make a surgical decision right away. You can say, okay, based on what I know right now, this patient is potentially resectable after induction therapy. Let's see how they fare as an overall person and patient while they get their induction therapy, and see if we're still thinking about surgery at the end of that line.
So esophageal cancer is a really difficult diagnosis to have. And even though surveillance can improve outcomes, there are a lot of reported figures at approximately 20% survival rate at 5 years for adenocarcinoma. What are your options for palliative treatment in these patients?
Oh, sure. Well, it gets back to the notion that the esophagus is actually a pretty simple organ, and its main job is to deliver, contents that have been ingested from the mouth to the stomach. And so if you have a cancer and it's obstructing that main function, then you're really looking at problems with swallowing and problems with nutrition and hydration. So the main two choices that you're offered are stents versus feeding tube. And so I think that the learner, the trainee, wants to really learn more about the nuances of stent versus feeding tube. And when I talk to patients, I talk about the pros and cons of each. The pros of a feeding tube is that it generally works. Once it's in place, it ensures nutrition even in the absence of appetite. And it's unlikely to migrate. It's unlikely to erode through into other organs, and it's very time-tested, safe, and user-friendly. On the other hand, the pros of a stent is that it allows oral intake in the way that humans are used to doing it. Is through the mouth. They get to enjoy the flavor and the act of eating, the social aspects of eating, and so there are definite selling points for that. But there are definitely unique situations. Like, for instance, at the GE junction, if you stent a GE junction tumor, you basically eliminated the lower esophageal sphincter, and you could have a wide open reflux that is so bad that patients will say, well, I like to swallow and like to eat, but I don't like all this reflux, so please take it out. And I've had that happen many times. So I think just being honest with the patient and guiding them through that particular choice is really helpful with regard to palliation of incurable esophageal cancer. And then the other aspects that you would consider as part of palliation would include things that the medical oncologist would also add, the pain management and kind of social support and that sort of thing.
Thank you, Dr. Meyers. And as we've started to shed a little bit of light on, the esophagus has a lot of different things that can go wrong with it. And so I'd just like to wrap up with a couple quick hits. What is the location in esophageal layers involved in a Zenker's diverticulum?
Okay, so this is a sort of roundsmanship again. And whenever diverticuli come up, the dichotomy that inevitably comes up is true diverticulum versus false diverticulum. And so in this case, in a Zenker diverticulum, just like in an epiphrenic diverticulum, and just like in a sigmoid colon diverticulum, it's a false diverticulum in that there's a weakness in the muscle that allows the mucosa and the submucosa to bulge out in response to pressure. So they're pulsion diverticuli bulging through muscle that are normally kind of knitted together to prevent that. And in this case, with the Zenker, it's going to be between the inferior constrictors of the pharynx and the cricopharyngeus muscle, and that's kind of a rounds trivia that the learners probably ought to just put to memory and kind of have that ready for the next time a case comes up.
And what is the test of choice for a patient with a suspected esophageal perforation?
That's a good question, and it sort of depends a little bit on the situation of the patient. For instance, you could have a call as a consult up to the ICU, and you've got a patient who's septic with an empyema, and they are showing some sign, sort of a hydropneumothorax, and the story was that they had forceful vomiting after eating a steak sandwich a couple days before. Well, you've got a really high suspicion that this is a Boerhaave's injury, but they're intubated, and so you're not going to get a swallow. You're going to definitely do an endoscopy, and that's pretty much the only thing that will do it. On the other hand, one of my colleagues was on call yesterday, and she received no less than 3 individual calls from different hospitals about patients that had mediastinal emphysema after vomiting. And all 3 of them were non-toxic, normal vital signs, and feeling okay, but they had CAT scans that showed air in their mediastinum. And all 3, she got a gastrographin swallow leading into a thin barium swallow. All 3 were negative, and none of the 3 ended up being transferred here. So I think that the contrast swallow is probably the most sensitive test of choice for patients with a suspected esophageal perforation. But patients who have that suspicion come in all types, and some of them are not able to undergo a swallow. So we have to be nimble and apply the appropriate test to the patient based on the overall situation with that patient at the time.
And lastly, what are some of the early and late complications of caustic ingestion?
Yeah, sure. So, and generally with caustic ingestion, what you're talking about might be bleach, or it might be some other, toxic substance that's been ingested, either by accident or as a suicide attempt. And probably the most feared initial complication would be injury to the airway. If there's some aspiration, that can lead to a respiratory crisis. But then if that toxic material got beyond the pharynx into the esophagus and sat there in the esophagus, it could lead to mediastinitis and sepsis. And then eventually it could make its way into the stomach and cause a transmural injury there and cause peritonitis. But generally, the initial necrosis of tissue that takes place after a caustic ingestion will lead to real early concerns about airway injury or oropharyngeal injury and respiratory problems. Later on, after the patients have recovered from that acute problem, then it becomes a long battle dealing with the strictures that would result from the mucosal injury. And so these can be really challenging, sometimes leading to the need for esophagectomy or more. But there's certainly different phases in the care of a patient with toxic ingestion. So, and those are I'll just add parenthetically, those are tough cases to deal with because in many instances they are suicide attempts, and if you are dealing with them as a thoracic surgeon, they were failed suicide attempts, and you can imagine whatever psychological distress led to that attempt is only going to be made worse by the burden of the medical problems that result from a failed attempt. So it's really a rough situation to deal with, both on a medical and surgical level as well as a psychosocial level.
Well, Dr. Meyers, thank you so much for being with us today. We got through a ton of great information about the esophagus. And as always, if you're looking to learn more or check out some more literature that we referenced in today's episode, feel free to look at the show notes. And a full review of the esophagus chapter can be found in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.